Welcome to the deep dive. Today, we're tackling something with a pretty serious sounding name. Malignant Fibrous Histiocytoma. MFH for short, I guess.
It is a bit of a mouthful.
Right. So we've got a good amount of information here, sources covering what it is, how you spot it, treatment, the whole picture, really.
Yeah, it gives a pretty solid overview.
And our mission today is to kind of pull out the key stuff for you, make it make sense,
Absolutely. Make it understandable.
And one thing that jumped out at me right away is the name itself. It suggests like fibroblast and histiocyte-like cells, but apparently where it actually starts, still a bit of a question mark.
Exactly. That's one of the really fascinating bits. The name MFH, it comes straight from what pathologists see, under the microscope. Cells that look a bit like fibroblasts. Those are the connective tissue builders.
Okay.
And histiocytes, which are immune cells. But the current thinking, it's more like NFH, is this group of, the term is primitive pleomorphic mesenchymal neoplasms.
Whoa, okay.
Yeah.
Break that down for us.
Right. So primitive means the cells aren't fully specialized. Pleomorphic, that just means they come in all sorts of shapes and sizes.
Ah, okay.
And mesenchymal tells us they come from mesenchyme. That's like the body's foundational scaffolding tissue in the embryo. It makes connective tissues.
I see.
So yeah, we see cells that look like fibroblasts and histiocytes, but the sources are clear, the actual origin, still not pinned down. Could be fibroblasts, could be histiocytes, maybe even these less developed mesenchymal cells.
Huh. So it's like looking at a mixed up batch of cells and trying to figure out the original recipe.
That's a pretty good analogy, actually.
Now, the sources also mention different types, histologic variations. Storiform pleomorphic and giant cell are the main ones.
That's right. Those are the two biggies.
What makes them different? And, what does that mean for the animal?
Good question. So both of these, the storiform pleomorphic and the giant cell types, they share this really key feature. They're locally invasive.
Invasive, like they spread into the nearby tissue.
Exactly. Think of like roots spreading out. They really infiltrate the tissues around them. And that, as we'll get to with treatment, makes getting it all out surgically, well, it makes it tough.
Right.
And yeah, they usually feel like firm lumps, maybe under the skin, sometimes deeper. The storiform pleomorphic one has this sort of swirling pinwheel pattern under the microscope. Storiform means matted or storied.
Okay, a pattern.
And the giant cell type, well, the name gives it away. Lots of big cells, multiple nuclei. They can look a bit like osteoclasts, the cells that break down bone.
Interesting.
There's also a myxoid type mentioned, which is sort of more jelly-like. And importantly, even though maybe older reports downplayed it, our sources say that for dogs, the chance of it spreading metastasis, it's actually considered moderate to high.
Moderate to high. Okay,
Yeah.
That's significant.
Definitely. And we absolutely have to mention the cat connection. Again, these sarcomas, they've been linked to injection sites in cats. That's a big point in the material.
Yeah, that injection site link in cats really does make you stop and think, doesn't it? About, external factors. So moving on, who usually gets MFH? Is it more cats, more dogs, certain ages?
Well, the info we have suggests it's reported more often in cats than dogs.
Oh, okay.
But biologically, how the tumor acts seems pretty similar in both species. Age-wise, for cats, the average is around 9 years, but it can range from 2 up to 12.
9 years average for cats and dogs.
Dogs are a little younger, on average maybe 8 years, with a wider range, less than a year old, sometimes up to 10 years. And it's interesting, there's no clear proof that males or females get it more often or, specific breeds overall. But the sources do call out flat-coated retrievers, Rottweilers, and golden retrievers. They seem to pop up more often in the dog cases.
So maybe some breeds are a bit more predisposed.
It suggests that, could be some genetic factors in play for those breeds, maybe making them a bit more susceptible.
Okay, so not exclusive, but maybe a higher risk for some retrievers and Rotties.
Got it. So, if an animal does get MFH, what are the first signs? What might you notice?
Well, it really can depend a lot on where the tumor is growing. But some general signs you might see, things affecting the whole animal, could be loss of appetite, maybe losing weight without trying.
Okay, just generally feeling unwell.
Yeah, lethargy, just not being themselves.
Right.
But the really specific signs tie into the location. When the vet examines them, the most common thing is finding this firm lump, usually under the skin in the subcutaneous tissue.
Firm lump.
And it's often invasive, meaning it feels like it's kind of stuck, maybe extending down into the muscle underneath.
Ah, okay, not just sitting loosely.
Right. And they can also grow near bone. Sometimes they even damage the bone or cause new abnormal bone to form around it.
Wow. Where do they usually show up?
The most common spots mentioned are the back, sort of between the shoulder blades,
Okay.
the limbs, and around the pelvis. But in dogs, it can also be a primary tumor inside the spleen. Inside the spleen. So you might not see a lump initially.
Exactly. The vet might feel an enlarged spleen during the checkup, what we call splenomegaly. And like we said before, it's really crucial to remember this cancer often spreads. Distant metastasis is common.
So a lump you find might just be the tip of the iceberg, potentially. Really highlights why you need to get any new lump checked out fast.
Absolutely. Prompt attention is key.
Let's talk about the why. You mentioned the cat injection link, but are there other known causes, risk factors?
Well, the sources are pretty upfront.
Yeah.
The exact cause. Still unknown.
Still unknown, huh?
Yeah. But it is interesting that you can induce these tumors in lab animals using carcinogens.
Carcinogens, like cancer-causing chemicals.
Right. Which kind of suggests environmental factors could play a role in pets too, potentially.
Makes sense.
And, like we keep saying, that injection site link in cats is a definite recognized risk factor. There's research trying to figure out why that happens. But beyond that, the specific triggers for MFH are still, well, mostly a mystery.
It's a good reminder, isn't it? How much we still don't know about why some cancers start. So, if a vet suspects MFH, how do they go about confirming it? What's the diagnostic path?
Okay, so the first step is thinking about what else it could be. That's the differential diagnosis.
Right, ruling things out.
Exactly. For a lump like this, you'd consider other soft tissue sarcomas, fibrosarcoma, leiomyosarcoma, tumors of muscle, fat, cartilage, bone, nerves.
Lots of possibilities.
Yeah, and also some immune cell diseases, histiocytic diseases, and mast cell tumors, which are pretty common skin cancers. Then you do the standard lab work, blood count, chemistry panel, urinalysis.
And what do those usually show?
They might show something, like maybe anemia or some chemistry values might be off, but, and this is important, they can also be totally normal.
So normal blood work doesn't rule it out.
Not at all. Sometimes vets do a fine needle aspirate, stick a small needle in, get some cells out. That might show those fibroblast-like and histiocyte-like cells we talked about.
Might.
Yeah, it's often not enough to be sure. Imaging is really key here. X-rays, yeah. They can show the mass, maybe show if bone is involved. And you absolutely need chest X-rays, usually 3 different views, to check if it's spread to the lungs. That's crucial.
3 views, okay, to get a full picture.
Right. But to really see how much it's invaded the surrounding tissue, MRI or CT scans are much better for that detail.
More advanced imaging.
Exactly. And ultrasound is super helpful for checking the abdomen, looking for spread to lymph nodes or the liver. Those are common spots.
Okay.
But ultimately, the definite gold standard diagnosis comes from a biopsy. Taking a small piece of the tumor itself and having a pathologist examine it under the microscope.
Histology.
The biopsy is the final word then. It sounds like a pretty thorough workup.
It has to be, really.
So when that biopsy does go into the microscope, what are the pathologists looking for? You mentioned there's some debate even among experts.
Yeah, that's a really critical point. There is a fair bit of discussion, maybe even some disagreement among pathologists about how exactly to classify MFH.
Oh, why is that? It's just complex microscopically. And that variation in classification, it might actually explain why you sometimes see different descriptions of how aggressive the tumor is or how it behaves in different studies.
Ah, I see. So the classification itself isn't totally set in stone.
Not entirely. But as we mentioned, those 2 main patterns are the storiform pleomorphic and the giant cell types. The storiform pleomorphic is sometimes called the inflammatory type, hinting at the mix of cells you can see.
Okay.
And the giant cell type, with those big multinucleated cells, sometimes called osteoclast-like. There's also the myxoid one we touched on. And a key thing is that many MFHs are graded as high grade.
High grade meaning?
Meaning the cells look very abnormal, they're dividing fast. That usually points to more aggressive behavior, more likely to spread.
Right, more concerning.
Definitely. Pathologists also use special stains immunohistochemistry, like molecular tags, really. Things like CD18, vimentin, desmin, a whole list of them. They help identify proteins in the cells, giving clues about their origin.
Do those stains give a clear answer?
Not always, unfortunately. Our sources say there isn't one perfect staining pattern yet that nails all MFHs. It's another layer of the challenge. And something else really interesting and pretty recent is finding that the type of MFH found in the spleen, microscopically, it overlaps quite a bit with other histiocytic diseases.
So even more blurring of the lines.
Exactly. Just shows we're still learning, still refining how we understand and categorize this cancer.
It really sounds like MFH keeps the experts on their toes, even at the microscopic level. Okay, so let's shift to treatment. If an animal gets diagnosed, what's the plan usually look like?
Well, because it's so locally invasive, surgical excision is usually the first step,
Yeah.
the main goal,
Cut it out.
right? But remember how it infiltrates, getting all of it out, getting those clean margins where there are no cancer cells left at the edge of the tissue removed? That's often really difficult.
Because it's spread out like roots.
Precisely. And that difficulty leads to a pretty high risk of it growing back in the same spot, local recurrence.
That's tough. What if it's on a limb?
In some cases, especially if it's very invasive or causing pain, amputation of the limb might be the best option for local control.
Wow, okay. Big decision.
Huge decision. And before even considering that, you absolutely have to check thoroughly for spread metastasis. Chest x-rays, abdominal x-rays, ultrasound, make sure it hasn't already gone elsewhere.
Right, makes sense. What about other treatments? Radiation, chemo?
Yes, radiation therapy can be really valuable, especially if the surgery couldn't remove everything, if you have dirty margins.
As an add-on to surgery.
Exactly, an adjuvant therapy. The success rates for controlling the tumor locally with radiation seem to be kind of similar to what you see with other high-grade soft tissue sarcomas.
Okay, so it can help clean up what surgery missed.
Potentially, yes. And then there's chemotherapy. That's often brought in if there's leftover tumor, if it's high-grade, or crucially, if it has already spread.
For metastatic disease.
Right. Doxorubicin-based protocols are common. The source even gives specific dog doses 30 milligrams per square meter IV every 3 weeks for dogs over 10 kilos. And 1 milligram per kilo 4V every 3 weeks for dogs under 10 kilos.
So quite specific regimens. It sounds like it often needs a combination approach, surgery, maybe radiation, maybe chemo?
Very often, yes. It's usually not just one thing. The plan gets tailored to the specific animal, the grade of the tumor, the location, whether it's spread, lots of factors.
Makes sense. And after treatment, what kind of follow-up is needed?
Because of that risk of spread, that moderate to high metastatic potential we talked about, follow-up needs to be pretty diligent. Regular checkups are key.
How regular?
Our source suggests rechecks, possibly with imaging like x-rays or ultrasound, every month for the first 3 months.
Monthly at first?
Yeah, then maybe stretching out to every 3 months after that.
Yeah.
Just keeping a close eye out for any recurrence or spread.
Okay. And if radiation was used, any side effects to watch for?
There could be temporary acute side effects, yeah. Things like moist skin inflammation, dermatitis, or hair loss in the area that got treated.
Okay, localized effects.
Usually. It's always best to talk to the veterinary radiation oncologist about what specific effects to expect for that particular treatment site.
Good advice. It really sounds like managing MFH requires ongoing vigilance from everyone involved. So, wrapping up our deep dive here, what are the main takeaways? The big picture on malignant fibrous histiocytoma.
I'd say number one, it's complex. The name is a bit misleading because the actual cell origin is still, well, murky.
Right, the mystery origin.
Yeah. Number two, seems more common in cats but acts similarly in dogs. Signs depend heavily on location.
Location. Yeah.
3, diagnosis needs that full workup imaging and definitely that biopsy for confirmation.
Biopsy is key.
And 4, treatment is challenging because it's invasive and can spread. Often needs that multimodal approach, surgery, radiation, chemo, and close follow-up is critical because of the metastatic risk.
That covers it pretty well. And it's just so striking how much is still being figured out, isn't it? Even the classification, like you said, veterinary oncology is clearly still evolving.
Absolutely. Which kind of leads to a final thought, maybe something for you to chew on.
Oh, lay it on us.
Well, we note about the injection site link in cats. We know carcinogens can cause it in lab animals. Makes you wonder, doesn't it? What other factors, things we don't even know about yet, might be involved in causing MFH or maybe other similar cancers in our pets. You know, what environmental or maybe genetic triggers are still out there waiting to be discovered.
That's a really interesting point. What else is contributing that we just haven't identified yet? Definitely food for thought.